Hello, I'm Peter Bovey and this is an immediate preoperative consultation prior to sleeve gastrectomy. Hopefully you'll have been on a very low calorie total meal replacement shake for the last 2 to 4 weeks and will have lost 5% of your total body weight. When you wake up in recovery after the surgery, you'll have a drip in one arm, you'll probably have a spare cannula in the other arm. If we're sending you to ICU, you'll also have an arterial line in one wrist. You'll have anti-embolism stockings on your legs, and on top of those are Kendall compression devices that squeeze the calves mechanically. You'll have Clexane injections twice a day into your arm or thigh to decrease the risk of getting a deep venous thrombosis, and you'll be a bit sore. Some patients have a PCA or patient-controlled analgesia for post-operative pain, but most patients don't actually need it. If you go to ICU, you'll also have a catheter in your bladder. The patients that do go to ICU usually spend the first night in intensive care, and the following morning their catheter and their arterial line are removed. They're given something to drink, they have a shower, they then go up to the ward. The others go directly to the ward after the operation. They don't have an arterial line or a catheter. Once you've woken up from your surgery, you can have some liquids to drink. I'm happy for you to get up and walk around. You'll feel a bit like you've been hit by a bus or kicked by a horse, but you should feel better every day. For the first 10 days after the operation, we have you just on liquids. And by liquids I mean anything that'll go up a straw and nothing that won't. Fluids that you can have at home include soups, as long as they don't have big lumps in them, tea, coffee, juice, water, or of course the very low calorie total meal replacement shake that you've been on preoperatively, such as Optifast. The operation is one that can cause a good deal of post-operative nausea, but the nausea always gets better. You're going to lose the most amount of weight in a week in the very first post-operative week, and most of the weight that you're going to lose in the first 9 months after surgery. But some of the bigger patients are still losing weight out at 18 months, 2 years. On average, people tend to lose somewhere between 0.5 kilogram a week and 1.5 kilograms a week, depending upon their starting weight. We talked about the risks of surgery. Bariatric surgery is actually one of the safest types of surgery that you can have. The risk of dying from a bariatric operation in Australia is less than the risk of dying from having your gallbladder out, and it's considerably less than 1 in 1,000. I haven't had to reoperate on anyone for bleeding in over 5 years, and I've only had to reoperate on one patient for a leak in the last 5 years, and that was several years ago. She spent about 4 weeks in hospital over a 6-week period, but she's now perfectly well and she's lost about 40 kilograms. I've also had 2 small leaks that didn't need a reoperation but did need a post-operative endoscopy and some IV antibiotics before they got better. It's possible to have side effects from weight loss itself, as well as complications from surgery. Nearly everyone that has weight loss surgery has some hair loss. The hair loss is usually temporary and it usually stops as soon as you stop losing weight. Almost everyone finds more hair on their comb or brush, but it's not often that I notice it clinically. If I think that it's obvious, or if you complain of hair loss, we'll check your serum zinc. Sometimes a low zinc is associated with hair loss, and I might send you back to see the dietitian, since often it's associated with diets that don't contain enough protein. I've had 2 girls come back wearing wigs, but they still had some hair, and their hair all completely grew back. I've also had 1 poor girl that lost every hair on her body. That's a condition called alopecia totalis. It's actually an autoimmune condition, but it's brought on by stress. And it can be the stress of a fright, an argument, a bereavement, a viral illness, or any operation. Or you can just wake up with it one day with all your hair having fallen out. I know of a prominent ophthalmologist in Brisbane who woke up one morning when he was a med student and all of his hair had fallen out. In my particular patient's case, she's an ICU nurse in her 50s. She's had eyebrows tattooed on and wears a little cap, and her attitude is such that she doesn't have to shave her legs or armpits anymore, and she's not particularly perturbed about it. There is a monoclonal antibody used for treating inflammatory bowel disease and rheumatoid arthritis. It's shown some promise in treating this condition, but it's off-label usage and it's very expensive. We're talking about $20,000 to $30,000 a year, so basically it's only used in alopecia totalis in clinical trials. Most people who've had weight loss surgery end up with some loose skin. Having said that, not all of them. And I've had patients that have lost 60 kilograms and have had very little loose skin and didn't want anything done. The younger you are, the slower you lose weight, and the more exercise you get, the less likely you are to want to have plastic surgery. A lot of the younger women plan on having plastic surgery once they've lost significant weight, but not many of the men or some of the older women. If you're contemplating plastic surgery, it's best to wait till you've finished losing weight, for your weight to have been steady for at least 6 months. And I think that it's best done in winter rather than summer, because it usually involves large wounds, and in summer you're more likely to sweat, and I think as a result have wound complications such as wound infections. And you're best to go and see a plastic surgeon to have the surgery. Some people go to cosmetic surgeons. In fact, there's no such surgical specialty. Cosmetic surgeons, GPs who've done a cosmetic surgery course. At least if you go and see a plastic surgeon, they'll have had proper training. Some people go overseas to have plastic surgery, and I think that's taking a risk. You wouldn't know what you're getting yourself into. And I know that some have had a pleasing result and a cheap operation and a nice holiday, but there have also been quite a number of disasters. There are certain surgeons I'd go overseas to see to have certain operations, but even I wouldn't have a clue what plastic surgeon to see, so what hope would you have? Don't be fooled by flashy websites and brochures. I occasionally will do an abdominoplasty on one of my patients who's had bariatric surgery and has a large pannus or apron, but I don't do any of the other types of plastic surgery. I don't do chins, I don't do facelifts, I don't do breast reductions, I don't do wings, I don't do thigh reductions or bum reductions, so you're really best to see a plastic surgeon. I'll generally only do an abdominoplasty if someone can't afford to see the plastic surgeon, or if they having, for example, an incisional hernia repair and have a big apron after weight loss surgery, which isn't all that unusual. The other common side effect of weight loss surgery is forming gallstones. Rapid weight loss is one of the causes of gallstones. We don't really know why. It probably has to do with the fact that after weight loss, the bile composition changes and becomes more likely for stones to crystallise out. That's the reason you had a preoperative ultrasound. But the fact that you had no gallstones preoperatively doesn't mean that you're not going to form gallstones as a result of rapid weight loss postoperatively. And that happens to, I think, somewhere between 5 and 15% of people after weight loss surgery. You're looking at someone that needed his gallbladder out within 12 months of having a weight loss operation. In fact, one of my siblings who's had a sleeve gastrectomy has also formed gallstones. And I would see between 5 and 10 patients a year who've developed symptomatic gallstones after having weight loss surgery who didn't have gallstones on ultrasound preoperatively. The earliest I've seen gallstones develop after a sleeve gastrectomy is 8 weeks. Some people put all their patients on ursodeoxycholic acid, which is a bile salt, to try and prevent gallstones. There's some evidence for efficacy, but it's off-label usage and costs about $50 a week. I don't know that the evidence is good enough to support putting all patients on it for that purpose. After the operation, you'll generally spend 1 to 3 nights in hospital. We keep you in hospital until you're comfortable enough not to need injections for pain or nausea and are drinking adequately. I'll get you back to see me at the office about 9-10 days post-operatively. Usually then, if you're managing well with fluids and you're comfortable, I'll tell you you're right to try soft food. But I wouldn't like you to do that without my instructions beforehand. In terms of returning to work and returning to normal activities, I tell patients they can do anything that's comfortable. I've had professional people return to work inside a week, 10 days after a sleeve gastrectomy. I normally would then get you back at 6 weeks post-operatively. The first 6 weeks after any operation is included in the operation fee as far as the Health Insurance Commission is concerned. Then I'll get you back at 3 months intervals for the first 12 months. At the 6-month mark, we'll do a blood test to make sure you don't have any vitamin or mineral deficiencies. And I'll repeat the blood test 6 monthly for the first 2 to 4 years. It can take a while to develop B12 deficiency, although one of my siblings and I developed it within the first 12 months. One of my other siblings took almost 4 years to become vitamin B12 deficient. If after 3 to 4 years you don't have any evidence of vitamin B12 deficiency, I don't think you need to have any future blood tests. After the first 12 months, I normally get people back for review every 6 months for the next 12 months, and then I'll see them once a year. The point of a review is really for my benefit, as I'd like to know how my sleeve patients do long-term with respect to their weight. If you do have significant weight regain, we discuss that at the time. If you have any questions, please feel free to ask me when you see me for the physical consultation prior to the operation. Thank you.